Welcome, Dr. Donatella. Thank you so much for being here with us. I would like to introduce you to our audience today. Dr. Donatella is an Italian board-certified specialist endocrinology and diabetology with over 26 years experience in treating patients with complex type 1 and type 2 diabetes, gestational diabetes, thyroid cancer, hyperthyroidism, thyroid nodule, parathyroid disease, obesity, and adrenal disease. She is currently working at Clemenceau Medical Center and is an advisor to THP Global. Thank you so much for being here with us today.
Hi, Zarmina. Thank you very much for inviting me and for your nice introduction.
Wonderful. Well, it is World Diabetes Month, and it's a very important topic for us to discover and talk about and ask questions about. So I would love to jump straight into it and ask you to share with our audience what is diabetes distress and what is the best way to ease it and get emotional and mental support when you are a diabetic.
Oh, thank you for this question. It's very, very important. Diabetes distress is the frustration that patients with diabetes have not be able to cope with the disease, which is a chronic disease. So you see, type 2 diabetes is a complex condition. It usually require management in lifestyle change, therapeutic, and is every day a reminder of how you need to approach this condition. Now, many patients cannot cope with that and they get in distress. Distress can lead to depression, and depression is very common in patients with type 2 diabetes. So it's very important to recognize patients in distress and support them. The first step is to recognize patients in distress. It's extremely important to involve the family. Patients with diabetes are lonely. They have to face every day a challenge to control their blood glucose with the fear of not be able to do, the fear of die earlier and develop chronic complications. So the first thing is to involve the family, make the family be aware about this burden. The other thing is the diabetes team to be aware about that, to support the patient, to not be judgmental. And also very important to screen patient for depression. So every patient with type 2 diabetes should receive at least 1 year screening for depression. When you recognize this, you should address in this way. And if the things escalate, also require psychological support.
Thank you. And Dr. Donatella, we hear a lot about CGM, which is continuous glucose monitoring. Can you tell us, is this effective for all types of diabetes, and when does it really come into the question for diabetics?
Yes, thank you for this question. So the continuous glucose monitor is a very important tool that is available for the management of diabetes. There are different kinds of continuous glucose monitor. Some are more complex, affordable, or less affordable, and definitely are necessary in patients who require intensive diabetes control. We usually advise to use this in patients on insulin, multiple daily injection, which are patients with type 1 diabetes. Can be very useful in elderly patients because they may be more prone to have a hypoglycemic episode, and this device usually can alarm other members of the family that an hypoglycemic episode is happening, so they can be aware and assist immediately. Can be also useful in pregnancy because pregnancy patients need to have a very tight diabetes control. So there are evidence that in this kind of patient, a continuous glucose monitor can help to manage diabetes and improve diabetes. However, it can eventually be used in patients they require less stringent control or management because but it requires really some kind of training. So a patient can use to learn the effect of what they do on blood glucose, and this increase their knowledge about how to manage diabetes. So these kind of tools need to be explained and need to have training in order to be used at the optimum level.
Great. And which insulin pump or CGM would be recommended for type 1 diabetic?
You see, this is very individualized treatment. So, first of all, we should not start patient on insulin pump without training. It requires a lot of education, not only on the tools, technical, but also about education about management of diabetes. We use insulin pump mainly in patients with type 1 diabetes, but it can be occasionally used in patients with type 2 diabetes. So the choice of the pump depends on different factors, including patient choice. So we have different pumps, more simple, more complex. It depends on how the ability of the patient to be engaged in the management of the insulin pump. So there is no one pump that fits all, but it needs to be personalized, as well as the continuous glucose monitoring, because as I say, there are more complex, easy to use, or also the price is also very big factor in the choice of these tools.
And how does, in general, diabetes technology and general technology help in managing diabetes?
I think they are essential with all the other part of the important management. So consider that even a simple glucometer is a technology, and we know now that the majority of patients can have easily access to glucometers. So this is the first available easy technology. However, as we already mentioned, continuous glucose monitor, insulin pump, and even more advanced way to use technology for diabetes is essential. There are a lot of applications can be used. They can help patients to self-manage either diet, physical activity, blood glucose. So it's very important to integrate technology in the management of a patient with type 2 diabetes.
And what is your opinion on advances in diabetes management? And could you give us some of those examples?
Advanced, if we mention about therapeutic treatment.
Yes, treatment.
Okay, yes. I can tell you that in the past 15 years, the management of patients with type 2 diabetes has changed drastically. Thank you to the discovery, introduction of a new class of medications. This has changed the way in which manage diabetes. So we move from looking just the blood sugar level to a more holistic approach. So there are new medications that has been licensed for the first time in 2005 from the FDA that actually has been studied extensively and found that they don't only are very powerful in reducing the blood sugar, but they can address other complication of diabetes, including obesity. And most of them also shows to be beneficial in preventing cardiovascular disease and reducing mortality in patients with cardiovascular disease and chronic kidney disease. So they are a very important part of the management of diabetes, so that many international guidelines, they start to consider this kind of medication in the first or second line management just because they offer extra benefit compared to more traditional treatment.
And is it recommended for diabetics to do the insulin resistance test?
No, really. No, it's not a test that will add any other information. So insulin resistance is actually a form of pre-diabetes. Very early in the stage of the development of diabetes, we see that insulin resistance can be one of the first kind of sign that the patient may be prone to develop diabetes. So when a patient has already developed diabetes, does not add any other information.
I think that answer would surprise some people. So that's
good
information.
Yeah, I know, because many patients want to do, I'm insulin resistance, I have diabetes. Okay, we already know that. Mm-hmm. So there is no really need to do this test at this stage. It might be eventually useful to do in an early stage. However, even early stage, we don't perform insulin resistant test. It's enough just to monitor a fasting glucose or to do a HbA1c, just to understand if a patient is in a pre-diabetic stage and therefore prone to develop diabetes in the future.
Absolutely. And once a patient has possibly reversed their diabetes, how common is it for them to have a relapse?
Okay, so this is a very important question. First, we need to realize that type 2 diabetes is a chronic condition and there is no cure for that. So it must be very clear. So there are now several clinical trials that has shown that type 2 diabetes can go to remission. And this happens when we can induce a significant weight loss in patients either with diet or with metabolic surgery. So in this kind of patient, we can achieve remission, and usually remission can be considered the normalization of the parameter, including the HbA1c, without any medication, specific medication for diabetes for at least 1 year. There are different guidelines, they have different definition, but we can say it's a sustained lack of alteration of blood glucose for a certain amount of time associated with a significant weight loss. This can be also sustained for a longer time. However, we can see that as soon as the patient starts to put on weight again, diabetes come back. So it's we will say go to sleep, but it's not really a cure. So it must be very clear that this is what it is at this stage.
Mm-hmm. And talking about gestational diabetes, what is the chance of having diabetes after facing gestational diabetes, and is there any risk to the baby?
Okay, so gestational diabetes is another very important topic. Yes, there is more risk. Patients who develop gestational diabetes are increased risk of having diabetes after. Indeed, 1/3 of patients following gestational diabetes will have some form of diabetes or pre-diabetes. We always suggest to repeat a glucose tolerance test 6-12 weeks after delivery, just to be sure they don't have any alteration of the blood glucose, and to reinforce preventative measures like continuous with diet, healthy lifestyle, and physical activity, and warn them about the risk. Even in the offspring, there might be some risk of develop cardiovascular disease or diabetes in the future. The data are still quite not clear, but there are some trends that this can happen.
So that brings us to the question, what role does genetics really play, and is there any steps to prevention one can take?
Yes, so diabetes is complex because it's an epigenetic disease. So there is a complex interplay between genetic and environmental factor. So while it becomes difficult to act on genetic predisposition, which is something that we are not yet able to do, we can definitely act on environmental factor when we know that one of the most prevalent environmental factor is the weight gain or obesity that is leading to the major increase in type 2 diabetes. So definitely act on preventing of obesity and improving lifestyle can help to reduce the risk of developing type 2 diabetes.
And at what levels would you say that a person's diabetes would be defined as controlled or uncontrolled?
Yeah, we have different tools to assess diabetes control. And usually this is easily done through a test. It's called HbA1c or glycated hemoglobin. This reflects the average of the blood glucose for the past 3 months. And we have as an average a level of 7%. Of course, this need to be personalized on patients, so it can become a state of art to define the target for every single patient. And also we look at the level of the blood glucose. We also have now other possibility to using continuous glucose monitor that can give you more deep information about how the blood glucose behave. So we will say that as average, a level of HbA1c of 7% represent a good control. However, if you have a young patient that doesn't have many complications, you can achieve strict control with a HbA1c 6.5% or even less if it's possible. Patients who are a little bit older and maybe with complication, we can go up to 7.5% or even higher if the condition of the patient are so advanced that do not allow more strict control. So need to be personalized, but roughly is around 7%.
And as a physician of diabetes, do you feel your patients are seeing you too much, not enough? And what is the right amount of frequency of a patient?
This is another very good question. So I can tell you by experience that we have patients that have perfect diabetes control and they want to come every 3 months, even less, and they want to do all the tests and they want to, really in distress. While unfortunately, those who are not doing well, they try to escape their control and postpone as much as possible to go back and see the doctor because they know their control is no good and they are, not compliant with medication or doing the right things they should do. So, yes, I would say that usually we should see patients with diabetes every 3 months. However, also this can be personalized because patients who have a very good diabetes control and is stable can be seen every 6 months. Patients who need more aggressive support, they may need to be seen even every month because education, ongoing change in medication can be more intensive.
And are there any screenings that a non-diabetic patient can do as a preventative measure? And what should they be and when should they be done?
Yes, there are, in many parts of the world, there are different guidelines that suggest when to start the screening. There may be different according to the local regulation. So usually a patient, we start to screen patient for diabetes over 40. In other countries, over 35. And if they have already risk factor like obesity or strong family history for diabetes, we can start even earlier. It's very easy to screen patients with diabetes because it's just one blood test that can be done, which can be either a fasting glucose or a level of HbA1c. So it can be included in a regular check that is done for the patient that, anyway, over 40, they may need to check cholesterol, they may need to check blood pressure. So part of this will be to screen them for diabetes.
Thank you very much, Dr. Donatella. That was a great session and we got to a lot of interesting questions and I hope that the audience found some useful information here.
Thank you very much. It was a big pleasure to be again here with the Health Bank and thank you.
This podcast is brought to you by the Health Bank Global.